Welcome everyone to today's webinar. I am Emma Goodman with Becker's ASC Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Belinda Garlick has more than 35 years of combined clinical healthcare and supply chain experience. Since joining the pre-source business at Cardinal Health, Belinda has participated in clinical and supply chain assessments of multi-facility healthcare systems. She has managed and collaborated with clients to achieve success in standardization, preference card management, and procedural supply cost reduction. Belinda is an expert in designing efficient supply consolidation programs for customers. Her consulting skills and supply chain management experience empower her to recommend clinical practice changes that optimize procedural supply consumption. She received her Bachelor of Science degree in nursing from Webster University in St. Louis, Missouri, and her diploma in nursing at Deaconess Hospital School of Nursing in St. Louis. Belinda has completed Yellow Belt training in Lean Six Sigma and has been a member of AORN since 1999. We are also thrilled to have Marvella Thomas with us, who has 35 years of clinical experience in healthcare institutions. Much of her experience as a clinical leader includes management roles in surgical services, central sterile and administrative services at acute and ambulatory facilities. In her clinical management roles, she was responsible for department planning, organizational effectiveness, and staff development. She was accountable for driving results that included fiscal and quality improvement activities with major emphasis on supply chain efficiency and inventory management. She has also managed 2 new facility construction projects. Marvella holds a Master of Science degree in nursing and a Bachelor of Science degree in nursing from the University of Missouri in Kansas City. She has been a member of AORN since 1972 and has spoken at local and international meetings. Belinda, I'll now turn the floor over to you to begin today's webinar.
Thank you, Emma, and welcome everyone. Thanks for taking the time out of your busy day to join us. In the next few minutes, Marvella and I are going to discuss specific strategies that can help you manage your ASC's operating room inventory more effectively, and that's especially important right now as surgery centers just like yours are challenged like never before to lower costs while maintaining patient throughput and quality of care. After this presentation, you should be better prepared to discuss why supply management in your operating room is important, describe the challenges of effective OR supply management, review the current processes, including clinical practices, used to manage OR supplies, outline strategies to improve OR inventory management, and in particular, we'll discuss how you can uncover hidden waste and discover areas of real savings. And we'll review how best practices from surgery centers across the country can be customized to meet your own unique challenges. And lastly, we'll review the roles and responsibilities of perioperative nurses in effectively managing OR supplies. So let's get started by sharing why Cardinal Health is uniquely qualified to help your ambulatory surgery center improve processes, lower costs, support patient safety initiatives, and streamline inventory management. With more than 40 years of experience, Cardinal Health is a recognized leader in transforming the healthcare supply chain to meet new challenges around costs, revenues, and outcomes. In particular, Cardinal Health is a leading med-surg distributor for the ASC market. Our clinical team of perioperative nurses average 20 years of OR and supply chain management experience. And we're here to help ASCs cut waste and OR costs both now and in the future. And a prime target for savings is your supply spend. Let's take a look at some of those numbers. For each surgical suite, the average ASC spends $230,000 on supplies and keeps between $100,000 and $120,000 per suite of inventory on hand. The average inventory turn is just 4.8 times annually. And as a percentage of revenue, ASC supply costs are substantial, ranging between 17% and 25%. Supply management takes a toll on the ASC staff as well. Up to 25% of clinical staff time can be spent on supply chain activities. A staggering statistic from a recent study at the University of California, San Francisco, has put a price tag on waste in the OR, almost $1,000 per procedure at that medical center. Although this statistic resulted from a study in an acute teaching facility, it should be considered when looking at your ASC supply spend in your centers. While supply cost pressures are a concern, so too is the average ASC overall financial health due to a number of factors. Several financial pressures are impacting the ASC today. For starters, surgery centers are paid nearly 50% less for the same service as hospital outpatient departments. And at the same time, ASC profits are declining as reimbursements fall. And the broader financial impact is as yet unknown. How will the shift in reimbursement guidelines from fee-for-service to value-based care ultimately impact ambulatory surgery centers? While the financial pressures loom large, so too does the opportunity. The fact is, most patients prefer ASCs over hospitals, which can be overwhelming and hard to navigate. In contrast, surgery centers can be more convenient, have better service, and feature lower out-of-pocket costs. To keep service levels high and costs low, surgery centers need new ways to cut waste and lower costs, and focusing on OR supply management is a prime opportunity. I will now hand it over to Marvella, who will talk about some of the challenges in managing your OR inventory.
Thanks, Belinda. So, to uncover the waste, we first have to recognize that supplies are duplicated in many areas. In fact, the same supplies can be found in the surgical suite, your OR core area, on specialty carts, case pick areas, on case carts, in your bulk storage areas, and then there are those non-official stocking locations, the manager's office and the nurse's lockers. 7+ locations where you can find exactly the same product, and many times those locations are only steps apart. So if you multiply this number by inventory dollars per operating room, the financial impact becomes overwhelming. So to cut this waste, ASCs need a new approach to managing OR inventory. But there are several challenges that they need to overcome first. Let's take a closer look. So managing OR inventory is no small undertaking. Some of your major challenges include the diversity of procedures. You're doing everything in your centers from simple eye procedures to major orthopedic and spine cases. You have physician preferences to deal with, and many times those are your high dollar items. You have typical practice issues, and there's a challenge of limited data, and some folks are even experiencing no data at all to manage their facilities. There are challenges with preference card management, and many times there's a lack of preference cards altogether. We just talked about the duplication of supplies, and there's a lack of automated inventory control systems in your facilities. And you have multiple categories of OR supplies to manage. You're managing everything from small commodity supplies such as Band-Aids to your complex implants and stents. So let's dig deeper into this first challenge, the diversity of procedures. Every day across the United States, there are thousands of procedures being performed, and each one requires a variety of supplies. There's little, if any, consistency in what's used and why. For example, the cost of supplies for a simple laparoscopic procedure can vary by hundreds of dollars from physician to physician or facility to facility. While different procedures require different supplies, many procedures require the same commodity items. However, few, if any, operating rooms have been willing to eliminate any supplies for fear of not having something the surgeon might request. In addition, past practice was more is better. Rarely would anyone run out of supplies in the operating room because historically the practice has been just in case. I have one on my back table, one on the shelf, and one in the drawer just in case it's needed. Imagine the waste that this JIC purchasing creates. So now let's move to your physician preference items. A study has shown that surgeons seek 4 things from healthcare facilities. They want quality, they want efficiency, they want input into decisions, and they want appreciation. So responding to physician preference requests demonstrates to the surgeon that the facility values them, respects their time, cares about their patients, and wants them to have an efficient environment in which to work. So this information supports the case that surgeon preferences do need to be considered when you're seeking to standardize products. But at the same time, many of the products used in your OR may be clinically equivalent and could be eliminated or standardized with little or no impact on your physicians. Physician preferences are also escalated in your ambulatory setting due to competition. Your ASC business development team often promises anything to get physicians on board without discussing the costs associated with physician preferences. So this is a disconnect that should be addressed with your business development team, your facility administrator, and your materials manager. And it's also a perfect example of why it's important to elevate the level of qualifications, experience, and skills of potential materials managers when you're hiring for this position. So now let's take a look at some typical practice issues that can be a barrier to effective inventory management. Effective inventory management in the operating room has been at best marginal. Standing in the way are such issues as the lack of data to support your inventory levels. Perioperative nurses tend to open everything on the preference card to ensure that they'll have everything the surgeon wants. It's kind of the old saying, it's better to have and not need than to need and not have. Many times the staff with limited knowledge are the ones that are actually purchasing, storing, and distributing your OR supplies. There's a lack of integration many times between materials management and your clinical services. Few operating rooms have established PAR levels. In fact, most of the time in the OR, your PAR level is filled to capacity. If my bin holds 100, there's going to be 100 in there. And that's because perioperative nurses are not inventory management specialists. Once again, have and not need rather than need and not have. But their focus needs to be on patient care and not on managing supplies. Many times your materials manager, who's the one trying to drive cost savings and manage the inventory, is often not valued or trusted by your clinical team. And in some facilities, materials managers are also required to function as clinical staff on a frequent basis. This gives them less time to manage the inventory they were hired to manage. So next, let's discuss the challenge of data analysis. There are several gaps in data analysis that ambulatory centers need to overcome. For example, there's a lack of quantifiable data regarding usage, your inventory levels, product duplication, and procedure costs by physician. Many of your facilities can tell you what their average procedure cost is, but they don't have the data to drill down to that cost by physician. So each of these issues has been a barrier to implementing processes that improve OR inventory management. Plus, many times the method of collecting data is still manual in many ORs. This lack of technology is limiting the ability to accurately determine where you are regarding annual spend, inventory levels, and inventory turns. And as a result, it's more difficult to set specific and realistic goals. So as another example, let's focus on a critical component of inventory management that would have been benefited by more robust data analysis, that of your preference cards. Physician preference cards have always been a guiding light for perioperative nurses. The challenge is that many ASC clinicians continue to use handwritten recipe cards. These cards tell the clinician what they need to pull, pick, and open for a physician's procedure, but it doesn't give the materials manager the data they need to validate supply consumption. And without that visibility, the visibility that the data analytics can provide, it's difficult, if not impossible, to align your inventory levels with actual product usage. And as a result, purchasing again is driven by that JIC, or just-in-case practice. And there are more examples of supply waste in the operating room as well. Product duplication is a major contributor to waste and a significant barrier to managing your OR inventory more effectively. There's not a day that goes by without a salesperson or a surgeon bringing some new and better product into your operating room. And there may or may not be clinical evidence that this new widget actually improves patient outcomes. So to sum it up, product duplication drives supply costs up in the operating room. One good example is just think of all the glove types from all the different glove vendors that you're probably stocking right now. Ask yourself if there are some duplicates that you could eliminate without impacting patient care. And that begs the broader question that Belinda will discuss: what can you do right now to gain better control of your OR inventory?
So opportunities to control inventory include product consignment, product consolidation and standardization, improved distribution and acquisition processes, and instituting a process to control new product flow and vendor access. So what's the first step in putting these opportunities into action at your centers? Improving your OR inventory management starts by bringing all the right people to the table. Organize a supply chain team that includes the ASC leadership, materials managers, physicians, and perioperative clinical staff. It's critical to educate and present the facts to the stakeholders as the first step. Those facts include the actual cost incurred of supplies, the cost of product duplication, and the variation in procedure cost and the cost of excess inventory. Education through sharing of information on these actual costs is critical. Depending on the stakeholder, the impact of the information will vary. For nurses, it is knowing the actual cost of supplies. Most often, clinicians are not aware of how much supplies cost, especially the commodity type items most frequently used. Here are a few suggestions to educate your staff on these costs. I have seen facilities add the cost of each product to the shelf next to the description and/or the item number. Your staff will see the cost each time they pull the product from the shelf. I've also seen the cost of product added to the charge ticket. And a fun thing to do could be to implement a guess the cost of the widget game. This could be done weekly at a morning report, or just play the game in the lounge on the education board. Then offer up a gift card to the monthly winner. All of these activities raise awareness and can encourage staff to pause before opening something that may not be needed. I'd like to share another idea to educate staff on cost of supplies that one facility came up with during a clinical assessment of their supply usage. The initial feedback from the staff was that the number of towels in all of their packs were necessary, but observations did not support this. There were stacks of towels in the anesthesia carts, on the SPD area, and in the locker rooms. So with permission from the clinical director, the number of towels in each pack was written on the schedule board along with the cost per towel. And it became a competition for the staff, who in this situation actually benefited from profit sharing in the facility, how many towels were truly needed in the pack to support their clinical needs. and they were shocked to learn they could save over $21,000 on the cost of towels alone in 1 year. And for physicians, benchmarking the cost of their procedures gets their attention. And in an ASC, that has a definite impact on distribution checks and profit sharing. The next step in educating your ASC stakeholders is just as critical. Have your entire supply chain team do a walkthrough of your OR operations with these points in mind. Visit all stocking locations and look for duplication and excess inventory. Look for those mission bins where product opened but not used is placed for donation. Observe the case pick processes and review pick lists for accuracy and have available items. Evaluate daily returns from the OR, and then at the end, review the group observations. Once stakeholders see your OR inventory issues firsthand, you'll be in a better position to gain the support you need to solve them. And once you have that buy-in, what strategies can you use to begin improving your OR inventory management? An initial step is to consolidate like products. The most painless and effective way is to select non-physician commodity products first. Most operating rooms have an excess of like commodity products, such as shoe covers or bouffant caps, soaps, and hand sanitizers. Consolidating these commodities can be as simple as standardizing from 3 vendors to 1. Another way is to reduce the number of OR stocking locations that Marvella referenced earlier, where individual products are stored. You can also combine individually pulled products into procedure-specific kits or packs, either standard or custom configured. Work with your vendors to develop appropriate kits for high-volume, supply-intense procedures. Base these kit solutions on actual procedure volumes, starting by grouping similar draping practices. Also, be sure to review your kits annually for item changes, waste elimination, and practice changes. Be especially aware of the need for a kit review if there's been a change in physicians, and a change of your procedure mix, or new techniques for surgery related to the product mix in your kits. And finally, as a part of this review process, include preference cards, case cards, and product return analysis. There are additional strategies for improving inventory management as well, such as looking for consignment opportunities. Work with vendors to identify consignment opportunities for high-cost products, such as orthopedic and spine implants and instrumentation. While you do, be mindful of the challenges with consignment, which include keeping an accurate account of what products are placed in the facility, and encouraging the vendors to keep consigned product to a minimum. And then finally, you need to consider managing the expiration dates. So let's move on to product standardization. Just 34% of ASCs use product standardization as a supply chain strategy, but it can be a powerful tool to cut waste and lower costs. ASCs need the leadership teams to drive this cultural change and stand firm in every decision to standardize. And the best place to start is commodity products that have little or no clinical sensitivity. As you implement your standardization strategy, work on reducing multiple or duplicate SKUs. Require clinically acceptable alternatives, and look for opportunities inside and outside of the kits. And to gain buy-in among clinicians, involve your vendors and sales specialists in product trials or sampling. And focus on such products as drapes and gowns, implants, and sutures. One of the roadblocks to standardization is a variation in equipment. This can be very costly if not considered prior to purchasing your capital equipment. For example, the disposable costs associated with replacing your surgical lights in the operating room will lead to a disposable cost for the sterile light handle covers that go on those lights. And the cost of the disposable light handle covers can be as low as 50 cents each or up to $15 each, depending on the type of light chosen. So imagine your increased cost per procedure with 2 new lights in each operating room that requires 2 $15 light handle covers per procedure. The next strategy for better inventory management is controlling the flow of new products and vendors into your ASCs. An unrestricted flow of new products and vendor access can result in tremendous waste and needless costs. To turn this around, the first step is to establish and enforce a policy and procedure on new product entry. The second step is to establish a multidisciplinary committee to oversee requests for new products. And finally, the third step is to control vendor entry and access to your staff. That way you can avoid the introduction of trunk products into your OR. Now that we've covered several strategies for helping you gain greater control over your inventory, what else can you do to reduce waste and cost while improving efficiencies in your OR? We recommend expanding the scope of your action plan to include critical clinical practice issues, such as eliminating waste. For example, often scrub techs scrub in to set up the case, then break before the patient comes into the room, resulting in the need to open another gown and pair of gloves. This practice costs approximately $4 each time they scrub in and break. So imagine every scrub tech doing that for each procedure, and in an average size ASC, 5,000 procedures are done annually. This unnecessary practice can lead to an increased cost for your center of $20,000 annually. Review practices for overdraping. Eliminating this practice is an excellent way of reducing costs. Choosing the right product for the right task. One facility was opening 12 surgical gowns for one doctor during a total knee procedure to provide a bump during that procedure. That cost was about $50. If that facility would use towels for this purpose instead, it would only cost approximately $15, still meeting the clinical needs at a fraction of the cost. Selecting the appropriate gown based on AMI levels for each procedure will provide the right level of protection and could lead to cost savings as well. Eliminating practices that do not add value or improve outcomes. Layering the back table with towels on top of a heavy-duty back table cover could be replaced by use of a 3/4 drape at a fraction of the cost. The 3/4 drape is also lower lint and will allow visualization of a break in sterility, whereas use of the towels for this purpose would not allow visualization of that break until after the towels were removed at the end of the case. And converting to and enforcing use of clinically acceptable, lower-cost product alternatives. To sum it all up, we've discussed why focusing on OR inventory management is important and how improving it can increase efficiencies, cut waste, and lower costs. We've also shared several strategies that you can use to improve your OR inventory management, which include not only focusing on traditional supply chain activities, but also clinical practices. Marvella will now give us some suggestions on how to put your own plan into action.
So to put your plan into action, take these 7 steps. The first step is to establish a baseline of what you're trying to accomplish. You have to have a starting point to know where you end. Second, set up specific and measurable goals to help you get there. Your goals also need to be realistic. You need to assemble your team of stakeholders and make sure that all of your stakeholders are engaged in the process. Determine the appropriate solutions to implement, and then develop your action plan to implement these solutions. Operationalize your plan, and finally, you need to measure and celebrate your success. So thank you again for your time and attention today. I'm now going to turn it back to Emma for questions and answers.
Fantastic. Well, thank you so much, Belinda and Marvella, for that fantastic presentation. And we will now begin the question and answer session for today's webinar. You can submit any questions you have by typing them into your control panel in the space labeled "Enter a question for staff" and clicking send. And we will try to get through as many questions as we have time for today. So it looks like we have a few questions that have come in already. And the first one is, this audience member says that it's challenging for them to truly understand how much waste they're reducing. And so what is your recommendation on how to best measure and quantify waste reduction?
So this is Belinda. I'll take a stab at that one. And it is a challenge to understand how to measure, that you are actually reducing the waste. I recommend that you first baseline where you are today with what you want to measure. I'll give you a few examples. You could tally the number of SKUs, and then after working on some consolidation initiatives, measure that number again, and then that way you can measure your success. You can also measure your total annual spend, then compare year over year after you've worked on supply cost reductions. Total inventory dollars is another way to measure your elimination of waste. And when looking at custom and or standard pack spend, always baseline today's procedure spend related to your pack program. This is key to capturing your total savings when making pack changes. Your rep can help you with this, but basically you take the current pack price, add in a single sterile price for any items added to the pack to establish your baseline procedure cost, not pack price. Then compare that to the total spend to the cost of the new pack, which has those new items included, along with the elimination of any waste from the pack program. And then one of the simplest ways is just to measure the reduction in spend. To measure your reduction in spend is comparing product costs between vendors. And we recommend you constantly measure your progress and document the savings, making sure to keep track of reductions, and as reductions occur, adjust your baseline.
Right. Thank you so much, Belinda. Those were some very helpful recommendations, so thank you for that. We have another question come in that says, an audience member says, today we are picking cases 5 days in advance, which is making it challenging for them to find space for storage. What would be your best practices for how many days in advance to pick for a case?
Well, I'll take that one, Emma. I can certainly understand the challenge of trying to find space to store and stage 5 days of procedures, because the number one challenge that most ambulatory centers have is a lack of space. So typically what that also would do to your inventory is you've just increased your days inventory on hand by having 5 days of inventory tied up on your case pick area. So that just inflates your inventory, increases the inventory dollars that you've got on hand. And also, while you've got those items staged on case carts or in baskets, someone is going into your supply room and reordering supplies. So once those cases, if you have a case that cancels and those items go back into the supply room, now you have additional inventory and your par levels are actually skewed. Also, procedures change. You know, your surgery schedule is extremely fluid, and there's a good chance that in 5 days of cases, you're going to have some cases that change, some that are added on, and actually some cases that are canceled. So typically, I only recommend that facilities pull cases 1 to 2 days maximum in advance. This reduces your inventory on hand and also frees up space.
Fantastic. Thank you, Marvella. That is super helpful. As a reminder to our attendees, you can type in questions that you have into your control panel in a space labeled Enter a Question for Staff, and we'll get through as many as we can with the time that we have left here today. The next question that we have coming in from the audience is, if products are delivered to me twice a week, how many days of inventory should I keep them on hand?
Well, I usually recommend that if you're getting 2 days a week delivery, to keep 4 to 5 days of inventory on hand. And that usually provides you with the adequate inventory to cover your procedures. You also need to keep in mind that you're going to have spikes in procedures, and you're also going to have, you're going to have certain times of the year where your procedures are increased. Typically in surgery centers, there's a 30% increase in procedures at the end of the year or the fourth quarter because everyone's trying to maximize their deductibles. So during the end of the year, you're going to probably have to increase your days inventory on hand to cover that spike, but also remember to decrease it when January rolls around and your surgery schedule drops down to normal again. So again, this may be an opportunity to work with your vendors on your unit of measure. When I say 4 to 5 days of inventory on hand, a lot of times you're required to order larger quantities than what you really need to maintain that inventory par. You may need a box of 20, but the vendor will only ship you a case of 100. So this may be a great opportunity for you to work with the vendor to get more logical units of measure delivered to your facility.
Great. Thank you so much for that advice. Moving on to the next question that has come in from the audience. This audience member says, it's sometimes hard to get my staff motivated to participate in these kinds of initiatives. So do you have any thoughts on how to incentivize their clinical staff and materials managers to get them on board?
Sure, this is Belinda. I'll take that one. I would say find out what motivates your staff. Everyone is different, and if you're lucky enough to be employed by a center with profit sharing, maybe this could be a motivator for change and cost savings. It will hit them in the pocketbook. Some clinical staff are motivated by best practices and being seen as the leader of the group. Get those folks on board with your initiatives and include them on your supply chain team. And then there's also those clinicians who are focused on eliminating waste. They don't want to fill the landfills with unnecessary trash. So these folks are often very willing to get on board with cost savings and eliminating waste. Just using these awareness activities we discussed earlier can be a fun way to get your staff motivated as well.
Great, thank you so much. And it looks like we have time for just one more question, and similar to the last question, this audience member is curious, what are the best ways to change practices that don't add value or to help improve outcomes?
This is Belinda again. Yeah, that can definitely be a challenge. Old habits are hard to break. I was one of those folks. Some of these habits can be left over from days of using linen or just staff training new staff, using old habits that really don't add value. From my experience, though, I have seen some successful ASCs do a couple of things. Review the AORN recommendations with your staff. I mean, you're constantly working in your ORs, turning your rooms over. Staff rarely has time probably to go in and review those recommendations. So reviewing them, maybe once a week, put a new recommendation up on the board, and that just raises awareness to the staff. You could find articles or studies online or in journals that provide clinical evidence on practice results. Or pull your team in to do the research process itself. Ask them to do the research on practices that you might feel don't improve outcomes, but they might feel is of benefit, and see what comes of that. Including them often helps to drive those behaviors, and they can come to the end result on their own sometimes. And as we all know, Google is a powerful tool these days, so there are ways that they can look at different resources to try to support what they want to do or their practices, and they may also find that that's not really clinically or providing a clinical solution for them. You can do a literature search to support the practices you may want to help change as well. And then also just reviewing the annual cost of what those certain practices that don't improve clinical outcomes are driving. Being a nurse in the OR prior to this role, I can say I was not aware of some of the costs associated with certain practices, and especially the commodity type items. And when you start adding it up year over year, it becomes a big number, and just being aware of those costs can help change behaviors.
Great. Well, thank you so much for sharing that. That, I think, is great and helpful advice for our audience. And it looks like that is all the time that we have for today's webinar. So I want to thank very much Belinda and Marvella for their excellent presentation, and to our audience for participating and typing in their questions today. We hope that you enjoy the rest of your day, and we look forward to having you join us for future webinars.